Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can find our previous episodes also on Apple Podcasts, Spotify, Google Podcasts, Stitcher Radio, and other RSS readers. Today, we're talking about medical cannabis for pain management in patients with rheumatic diseases such as rheumatoid arthritis and fibromyalgia. We'll first start by understanding what cannabis is, why we have an endocannabinoid system in our bodies, and how cannabis can affect it. We'll look at the current research in medical cannabis for the treatment of rheumatic diseases. We'll discuss contraindications for cannabis use, and also where and how to get medical cannabis. With us today is Dr. Marianne Fitzcharles. Dr. Fitzcharles is an associate professor of medicine in the Division of Rheumatology and at the Alan Edwards Pain Management Unit at McGill University in Montreal. She was a lead on the Canadian Rheumatology Association position statement on medical cannabis and is the co-chair of the American College of Rheumatology Pain and Fibromyalgia Abstract Committee. Her work focuses on pain management in rheumatic diseases, with publications addressing the use of opioids and cannabinoids in patients with rheumatic diseases. Marianne, welcome to the show.
Hello, John. It's a pleasure to be with you today from Montreal in springtime.
Oh, fantastic. Yeah, yes. So I'm in Boston. Today's been a weird day. There's been sunny and showers, and now it's sunny again. But that's the weather in the Northeast.
We have blossoms in full bloom, so it's wonderful.
Beautiful. I got to get up there sometime soon. So, I went to medical school about 15 years ago, so in the early 2000s. And at that time, I remember learning a lot about pain and mostly about using opioids to treat pain. So at that time, the discussions were which opioid to give, how to convert short-term opioids to long-term opioids. And things like cannabis were really looked at in a very negative light. I think at the time, the medical establishment considered cannabis to be a dangerous drug with no medical value. And, fast forward 15 years, it seems like it's the complete opposite. Opioids are now looked into a very negative light, and cannabis is sort of having a resurgence of interest and applications. Can you tell me a little bit about why that happened?
Well, I think the most important thing is that cannabis has been an illegal drug in most of the world for at least 100 years. And that was the biggest hurdle. Cannabinoids have been used in medicine for over 5,000 years. Cannabis is still one of the traditional plants in Chinese medicine. So there is a long, long history of the use of cannabis or cannabinoids to treat many different complaints, particularly pain, anxiety, sleep disturbance. But because it was an illegal product, it was impossible to do research. It was impossible to access the product other than if you were using it recreationally and illegally. So in some states in the US, beginning with California and then in Canada, we've had access to medical cannabis for probably about 20 years. And that access initially was fairly confined, fairly limited. But as we have got to use or got the experience of our patients using it more commonly, I think we've become more open to understanding, what does it do? Does it do anything at all? And then clearly, with recreational cannabis being legalized, we now have much, much easier open access to the product. And what we're seeing now is patients are experimenting commonly on their own to see whether it works.
So, can you explain to me a little bit more about sort of cannabis? I hear or marijuana. That word is tossed around, and there's also the components of it, like THC and CBD. How should we better understand what cannabis is and its various different sort of formulations?
Right. So the first thing is that as physicians, we should talk about medical cannabis. We should not use the terminology marijuana. And the reason is marijuana has got connotations of recreational use. So let's talk about medical cannabis. When we think of cannabis or cannabinoids, we can think of two big categories. There is one category, which are the pharmaceutical products, which are manufactured. They have GMP. We know what the dosages are. There are indications. There are contraindications. They are FDA approved, etc. These are pharmaceutical products. And then we have the herbal product. Now, when we look at what we know about the effects of cannabinoids, and when we think of the efficacy or the harms, we must remember that most of the studies have been done on pharmaceutical products. What has changed now is that our patients are using the herbal product, and we really and truly don't know the ideal dosing. We don't know the ideal combination. We don't know the ideal strain. So there's quite a conundrum at the moment. When we think of the cannabis plant, the most common strain is Cannabis sativa. There are over 1,000 molecules in this plant, which is quite mind-boggling.
Wow.
The two that are most commonly studied are tetrahydrocannabinol, THC, and cannabidiol, CBD. But there is a whole mass of other molecules that are cannabinoid molecules and non-cannabinoid molecules in this plant. And these other molecules, which we identify as terpenes and flavonoids, they're the molecules that give the smell to the cannabis plant. But also, there is a theoretical possibility that it's a mixture of some of these molecules that really has a therapeutic effect. Because when we look at the pharmaceutical product, so there's a particular product called nabilone, which is a synthetic THC. And nabilone has been studied in a number of conditions, particularly fibromyalgia. And it's not the greatest of great medications. Patients often say they get a lot of side effects and all of that. Whereas the proponents of the use of medical cannabis say, well, that was only one molecule. You've missed out on the entourage effect. So it's a mixture of all of those other molecules that are very important. So that's where we are. And the big conundrum for us is that the plant itself, even if you have a single strain, the molecules in the strain will change from production to production, depending upon how the plant is grown. Is it grown indoors or outdoors? Was the light good? Was the water good? Was there good fertilizer or not? So even patients who are using medical cannabis and are accessing the same strain will sometimes tell us, well, somehow the product that I got this month just doesn't seem to do as well.
And as I understand it, sort of in a simplistic way, the THC molecule has more of that sort of euphoric brain effect, whereas the cannabidiol, the CBD, maybe does not. Is that right?
That sort of leads us into why cannabinoids? And we have an endocannabinoid system in our body. And the endocannabinoid system is very, very important in development, in neurological development. It's very important in regulating mood, regulating appetite. And it's essentially the system that brings us back to rest and respite most of the time in the adult. Now, the receptors in the endocannabinoid system, we know definitely of two, and there probably are a number of others. There's the CB1, CB2 receptor. The CB1 receptor is mostly on neurological cells, it's mostly in the nervous system. And the CB1 receptor is the receptor that is activated by THC and causes the feeling of high. The CB2 receptor is very interesting because it's predominantly located on immunological cells. And we're not totally sure exactly what it's doing. But then let's just jump back to CBD. Now, even although CBD is a cannabinoid and it's structurally very, very similar to THC, excepting it's got not a closed ring, but a hydroxyl ring, CBD does not engage very well on the CB1 or CB2 receptors. So it has very low affinity for these receptors, but actually works quite definitively in some of the pain modulating receptors, such as TRPV1, etc. So the THC with activation of CB1 is what people look for the recreational use, whereas we really want to try to do the best we can to get mostly pain modulation for our patients. And that's why when we are talking about cannabinoids to our patients, we'll generally say, take something with a very low THC concentration.
That's really fascinating, and thank you for explaining that. You mentioned pain, and we're going to be spending a lot of time in this episode talking about pain and cannabis use in specific, to treat pain. How do you understand what pain is?
Well, pain is what the individual feels, and we all feel pain differently. But when I went to medical school, which was before you went to medical school, we talked about the sensory distribution of pain. And we all remember that little homunculus on the brain, the somatosensory cortex, with the very big hand close to the face. And that is the location of pain. But it's only in the last 20 or 30 years that we've appreciated the affective component of pain is as important. And this affective component of pain is much deeper within the brain structure, in the anterior cingulate gyrus and the thalamus and all of those bits of the brain. And it's really important to appreciate that it's not just the sensory component. We've got to think of those two components. And the affective component of pain is often the part that causes the greatest suffering. And this is the component that is associated with mood disturbance, people feeling down, feeling depressed, probably fatigue as well, difficulty with sleep. So pain doesn't occur in isolation. Pain occurs associated with these other factors that are very important in impairing the quality of life. And when all of that is going on, your total function, your total quality of life is reduced. And this is why people have been looking to cannabinoids and saying, well, what about an agent that could perhaps impact upon the pain, but also do something to, say, sleep? And maybe give us a little bit of relaxation, reduce anxiety. Wouldn't that be great? And this is why cannabinoids have held quite a big promise.
How did you get involved in thinking about using cannabis for the treatment of pain?
So as I said, in Canada, we've had access to medical cannabis for about 20 years. And although I am a rheumatologist, I'm also a pain medicine physician in Canada. So I sort of straddle these two specialties. But as the years have evolved, I think we have come to the understanding that pain is a very, very important component of suffering for our patients with rheumatic diseases. You know, we were very focused in the past on doing everything, and we still are very focused on getting good control of inflammatory diseases. But we do know that even with beautiful control, many patients still have a remaining pain or a secondary fibromyalgia, or what we now call today a component of nociplastic pain. And nociplastic pain sort of opens up a whole new era for us, because nociplastic pain does not respond to our traditional pain medications. So nociplastic pain doesn't respond well to opioids, to anti-inflammatories, but this is why we are using some of the anti-epileptics, some of the antidepressants, and now possibly cannabinoids.
I like that word, the nociplastic pain. I guess, in medical school, the way I learned about pain is that if there is a damage to a part of the body, this is sort of the body's response telling the brain, okay, don't step on your foot because the foot is broken, right? So it's sort of an indicator of damage. And, once the foot heals, then the pain resolves. But we've all seen patients that, either after injury or even with, as you mentioned, with better control of the rheumatoid arthritis, they still have pain.
You're absolutely right. So, what you've explained is exactly our old concept of pain, that there were two mechanisms: nociceptive pain, so that is the damaged knee joint or the damaged rheumatoid joint; neuropathic pain, when there is particular damage to nerves. But now our understanding of nociplastic pain is that this is pain that is out of proportion to any perceived tissue damage. And it's as though the nervous system is just fired up and it's in overdrive. So there might be a peripheral initiating event, such as osteoarthritis of the knees, but the nervous system is then fired up. And this pain generally does not respond to our traditional analgesics.
Fantastic. So tell me a little bit about some of the evidence about the use of cannabis for this type of pain or any type of pain.
Right. So this is our big, big problem. As academics, as clinicians, as doctors, we look to evidence-based medicine to direct our treatments. And the gold standard of evidence-based medicine is randomized controlled trials, and then the systematic reviews, and then the meta-analyses, and then the guidelines. We do not have this for cannabinoids. Most of the studies on cannabinoids have been done on the pharmaceutical preparations, and we have almost nothing addressing the effects of herbal cannabis, particularly in rheumatic conditions. And I'll give you a number that's quite mind-boggling. There have been less than 200 rheumatology patients studied in RCTs looking at the effects of pharmaceutical cannabinoids. There have been 58 patients with rheumatoid arthritis and a handful of patients with fibromyalgia and a few patients with low back pain. So we cannot extrapolate what we know about the pharmaceutical products into herbal cannabis because they're totally different things. So what we've had to do is we've had to look at cohort studies We've had to look at studies from surveys, patients self-reporting. And we know that these types of studies are not ideal, but it's going to be the way that we're going to have to accrue the evidence. And when we look at these cohort studies, you've got to say, well, where do they come from? Many of the cohort studies have come from dispensaries. They have come from the growers in Canada or surveys. And when you have surveys for the public, the diagnoses are self-reported, and we know that's not quite so accurate. And when we look at many of these cohort studies, and particularly where they come from, patients report very good effect. But we've still got to take a few steps back and say, is this absolute reality?
Fascinating. So, I've certainly had the experience where some of my patients say, oh, I took THC and I feel so much better. And other patients say, I took THC and it didn't help, or I took THC and I had side effects. Do you ever recommend trying cannabis for any of your patients with either pain or with rheumatic diseases? Or is this something where they themselves bring it up and say, hey, doc, I'm taking, a CBD preparation. What do you think?
So we've done actually 2 nice studies in Montreal where we surveyed 1,000 rheumatology patients as they were coming through the clinic. This was before recreational legalization, and we did it again after recreational legalization.
Interesting.
So what do we find? Well, we find that since recreational legalization, the number of patients trying medical cannabis has doubled. So in our clinic, at least 30% of patients have tried it, whereas previously it was only about 15%. Once patients have tried it, the continuation of use is probably in the order of 30 to 40%. So not everyone continues use. Patients now are trying it themselves. So not necessarily coming through the medical stream because they can just go and buy it totally legally. When patients have tried the medical cannabis, I'm always happy that they want to discuss it with their physician. Because I think if a patient is using a product as a medicinal product, we need to be part of that conversation. So I'm always very, very encouraged and empathetic when they raise the issue. What we are seeing now is previously, probably 10 years ago, cannabis was tried mostly by younger patients who had previously had recreational experience, often younger males. But that is changing. Those demographics are changing now. And we're seeing much more women, older patients. The average age is sort of in their 60s, not smoking so much, but more commonly using the oral products. And again, the continuation of use is something that really needs to be better understood because we have very, very few longitudinal cohort studies. So they literally are, we've just done a little systematic review, and they were in chronic pain. And there were only 6 longitudinal studies longer than 6 months. So that's not very, very much. So there's a lot of work to be done and a lot of information to be collected.
Yeah, certainly. I think, when my patients bring it up, the use of cannabis, certainly makes me think that, I'm not doing a good enough job in managing their pain. And, I think pain is such a difficult thing to get a handle on and to try to, better understand it. As you mentioned before, what is causing the pain? Is it you called it nociplastic pain?
Nociplastic. It's now the 3rd mechanism of pain by the International Association of the Study of Pain, IASP.
Fantastic. So yeah, I think we probably don't do a good enough job in differentiating the different types of pain and providing treatments for pain. If it's a broken foot, you might think of, one type of pain medications versus this nosoplastic pain, whereas you mentioned the anti-inflammatories may not be as effective. But I think the fact that they are looking into these, what are called sometimes alternative and complementary medicines sort of tells me that we're not doing a good enough job in managing pain in general. And this is why patients sort of feel like they need to seek other ways of managing pain, such as cannabis, and in which case, maybe it's a great thing.
Right. And you're right. Our analgesic medications generally for chronic pain are not very good. They're very, very good for acute pain. For people living with chronic pain from day to day, they mostly provide a modest effect and so many side effects.
Yeah, I saw a recent study suggesting that part of the reason why people develop chronic pain may be the use of NSAIDs initially, that you're preventing, a mechanism by which the body heals and the nerves heal. And by using NSAIDs early on, maybe that, increases the risk of chronic pain in the future. I think there's still a lot that needs to be thought about. So when patients discuss sort of the use of cannabis, are there concerns about, adverse effects of cannabis use? Can anybody use it? Are there any contraindications in terms of, maybe comorbidities or other medications that they're using?
So this is really a very, very important point. I think the first thing one needs to do is in the dialogue with the patient to understand what is the symptom that the patient wishes to treat. Number one. And number two, is it appropriate? Have other treatment options really been explored? Have non-pharmacologic treatments been explored? Someone who just wants to sit on the couch all day and I don't know, eat their candies and watch the television. They need to be instructed in non-pharmaceutical treatments. So we mustn't forget those. But once you've come to the conclusion that perhaps it might be a reasonable thing for this patient to try some medical cannabis, what can we suggest? So the Canadian Rheumatology Association actually put out a pragmatic position statement on medical cannabis for our patients. And the overarching principle is do no harm. Once we've got to that, we have to look at the individual patient. And there are certain patients where we have great concerns about the use of any cannabis. And this is firstly the young person with rheumatic diseases, the teenager whose brain is still developing. And cannabinoids, the endocannabinoid system, is very important in developing this very good brain circuitry. And our brains still continue to develop until we're in our early 20s. And boys take a little longer than girls to get their brain to mature completely.
Yes, I could see that.
I have real worries, and we generally have worries about cannabis use in the adolescent person. So, number one. Number two, the pregnant patient. And we know that the cannabinoids do cross the placenta, and there is absolute evidence that there is risk and harm to the fetus. So the pregnant rheumatology patient, and I know a lot of the dispensaries, particularly in the States, are advocating the use of cannabis for the treatment of nausea with pregnancy. No, not at all. And then let's move to the functional person. So the young woman with fibromyalgia and a young family. What do we do when we're functional? We drive. And even a little bit of THC has got impact upon our psychomotor function. And driving ability is reduced. So if you've got some cannabis in your system and you're driving, you're a very careful driver. You drive more slowly. You tend to weave lanes just a little bit. But your acute response reactions are markedly impaired, period. So we now know that there is increasing road accidents, there's increasing trauma related to cannabis on the roads. But this is cannabis in general, but it's not, and this will apply also to medical cannabis. So we've talked about the young person, the pregnant person, the functional person, and we have now to talk about our elderly patients. And there are a number of considerations to be thought about. So we know that older people certainly have more comorbidities, they're on more medications. The interaction of cannabinoids and medications is theoretical as opposed to known evidence that there is the chance of really changing the metabolism, particularly of the anti-epileptics, antidepressants, the anticoagulants with reduced concentrations of anticoagulants, and actually tofacitinib as well. So drug interactions that are mostly theoretical, but we have to take this into consideration. And then our older patients, there's psychomotor effects. We know that by the time you're 60 years old, and that's considered to be older today, 1/3 of people over the age of 60 fall each year. And if you've got cannabis in your system, your likelihood of going to an emergency room because of a trauma is double that if you do not use cannabis. So, older people, greater risk of falling, greater risk of injury, greater risk of motor vehicle accidents. Don't really know what it does to an older person cognitively. So, those are sort of the big four categories that we really have to keep in mind.
Got it. So when you have a patient who's not in one of those categories, either too young, too old, pregnant, and who's interested in trying medical cannabis, do you prescribe it or do you send them to a dispensary? How does the process work?
So, as a physician, both in the United States and in Canada, we cannot actually write a prescription for cannabis. What we do is we authorize use. So I am quite happy to authorize use for patients, and I have a number of patients that have requested a trial of cannabis. So, having had a discussion with the patient, how do we go about it? Firstly, strongly recommend that it's not inhaled. So we tell all our rheumatic disease patients, don't smoke, because we know smoking has got an adverse effect upon their rheumatic disease. We don't really know what cannabis does. But a good indication is don't smoke it, don't inhale it. If you're going to take it, at least take an oral preparation. But we know that the bioavailability of the oral preparation is quite low. So bioavailability of THC and CBD is probably less than 10%. So it's not very well absorbed. If they're going to use it, at least take it in a capsule or an oil. And we generally say begin with a very small dose at nighttime. So very low THC, more CBD, and in the order of about perhaps 2.5 milligrams at night. I really encourage patients to understand and know exactly what the product is that they're using, to get it from a legal avenue, not off the street because you don't know what's in the stuff, not an artisanal CBD product because we don't know what's in those bottles. The FDA has already issued warnings to the artisanal people because of the inaccuracy in the labeling. So at least get it from a regulated provider. Start with a tiny dose at nighttime and see how you feel. But with the knowledge that even a tiny amount of THC can cause psychomotor effects. So they've done studies looking at, in fact, there's a lovely meta-analysis looking at doses of THC that can cause psychomotor effects. and even 1.25 milligrams of THC, a tiny amount. And imagine your little old man of 80 with bad OA of his knees who takes a little bit of cannabis oil, which he thinks is mostly CBD, but it's got a bit of THC in it in the middle of the night, little confused, getting out of bed, falling and fracturing. So what we say is don't smoke, take it orally, and start with a small dose at night.
Yeah, and I guess from a licensed dispensary, going on Amazon and getting CBD oil and all of those things, I guess it sounds like you don't know what you're getting.
And it's, they've done studies in Canada, US, and in Europe where they've accessed the CBD artisanal products, and the accuracy in labeling is very, very poor. So it doesn't really bother me very much if there's nothing in the bottle. If it's a good placebo, that's fine.
Yeah.
But what is very worrying is that in many of these products, there was additional THC, and there was synthetic THC, and there were contaminants. So, at least get from a licensed producer. I want to just add one thing. When I was talking about who we should be cautious about, I want to add one extra thing about the elderly. And that is, when you take THC is a vasodilator. So you see pictures on the internet of these young people with bloodshot eyes. So it's a vasodilator. That's fine. Vasodilator, well, the blood pressure could drop a little bit, but it's a vasoconstrictor of coronary arteries. And it's a vasoconstrictor of cerebral arteries. And it also has prothrombotic effects on platelets.
Not a good combination, those three things.
Certainly in Canada, we are now seeing children coming into the emergency rooms with myocardial infarctions. So very cautious about someone with cardiovascular disease.
So when you mentioned about the preparation, that patients should be aware about what preparation they're getting. Are there preparations that are only CBD and not the THC? Do they all have THC and CBD? How do you choose?
Right. So the hemp is cannabis sativa with less than 0.3% of THC. So if you have a product from a regulated grower produced from hemp, you will have very, very little THC in it, okay? But all of the other products that we access, certainly in Canada and the regulated growers in the States, will all have a certain amount of THC, and certainly more than 0.3%.
Got it. Okay, that's very clear. And just to wrap up, what are some of those other things that patients should be doing for their chronic pain? You mentioned that there's a lot of things that should be done to manage chronic pain before thinking about medical products, including medical cannabis. With people with fibromyalgia, even osteoarthritis, what's your approach on managing their symptoms?
So we really want to emphasize good lifestyle practices. That's really, it's the bread and butter of medicine, isn't it? A regular routine. Make sure that your diet is a good diet. If you're overweight, bring the weight down. And physical activity. We're very, very lazy people. We get in the car, we take the bus, we don't walk anymore. And I always ask patients, what health-related physical activity are you doing? And sometimes they'll say, well, I'm doing nothing. Because people think health-related physical activity means going to the gym. No, it means going for a walk outside, gardening, doing chores around the house. So we really want to emphasize those good health-related activities. Good sleep, not too much sleep, but not too little.
Fantastic. Great. I think this has been a wonderful discussion and certainly kindle to think about the use of medical cannabis in our patients. It sounds like there's still a lot of research that needs to be done. So for any of you out there, I think this would be a great, Rheumatology Research Foundation grant or NIH grant to study the use of medical cannabis in people with rheumatic diseases or chronic pain syndromes. It sounds like we still have a lot to learn, but I think based on our discussions, it seems like it's potentially can be very useful for the right patient.
You're absolutely right.
Great, Marianne. Well, thank you so much. It's been really wonderful speaking with you. I really appreciate your time. Hopefully, next time I'm in Montreal, I can say hello.
Thanks, John. It was fun to have a chat with you today, and to all of those out there in the big wide world.
Great, thank you. Well, that's it for our show. Thank you all for listening, downloading, and subscribing to ACR On Air. Be sure to follow us on Facebook and Twitter at ACR Room. We'll be giving you updates that you won't want to miss. And as always, please stay healthy.